So ALK is a gene. It stands for anaplastic lymphoma kinase. And actually, the reason it's called that, it was first discovered in a different cancer than lung cancer. It was discovered in a type of lymphoma called anaplastic large cell lymphoma, and that was many years ago. The way ALK got into the lung world, though, was that a group in Japan discovered that there are particular changes in this gene, this ALK gene, in a small subset of patients. And what happens is because the chromosomes are rearranged, you now basically turn on this ALK gene when it normally never would be on in the lung. And by turning it on now, you stimulate the growth and proliferation of the cells and drive the formation of the cancer. So that was discovered back in 2007, as you know, and at that time, there was already a drug in the clinic, crizotinib or Xalkori, that was very early on in phase 1 testing. Although it wasn't being tested for ALK specifically, it was actually being tested primarily for another type of gene called MET. But once that discovery was made that ALK was a potential target, or what we now call an oncogenic driver in lung cancer, we started identifying patients. This is at many sites around the world, started identifying patients like you and enrolling them on this phase 1 study of crizotinib. Want to continue on?
So from a personal point of view, and Alice and I both lived through this, so that phase 1 study started in 2006. So the phase 1 study of crizotinib in people started the year before ALK was discovered in lung cancer. And they knew it was an ALK inhibitor, but as Alice has said, ALK had only been described in lymphoma. And so the sponsors of the study, Pfizer, had always said, if you happen to find an ALK lymphoma, and I spoke to the hematologist, and they said, well, you're never going to see one of those. And then it was one of these kind of perfect storms. So there were 5 sites in the entire world that were doing the study, and totally by chance, the investigators at each of the sites happened to often be a thoracic oncologist, or at Mass General, they quickly brought in Alice as a thoracic oncologist, and the kind of lung story spun off by itself. And I think the very first patient was treated at the end of 2009?
2007.
2009.
No. The very first ALK positive patient came on at the end of 2007.
Really?
Yeah, he was in dose escalation. And it was December 26, 2007. He was very, very sick, and had one of these.
What time?
He actually went on at the 300 BID dose, and he had a really dramatic response. And so I think it was very clear, even from that very first patient, that this was a potent drug in this particular type of lung cancer. And then the next patient was, of course, at the BI, Dan Costa's patient in 2008.
And then the expansion was in 2009?
Started
Throw me a bone here.
Well, the expansion started in about September, October 2008.
Okay.
And
My daughter was born in 2009.
Thank you. That was exactly what I was thinking of.
that must be the confusion.
Yeah.
It was either.
Actually, my daughter was born in 2009 too, so I'm checking out for that year.
But let's talk about the number, what I have shown here, and they're seeing is the proportions of ALK in a few different things. And it's about 3 to 5%. Is that holding up? And maybe you can talk about the different patient populations by race and smoking status and any other factors that, for instance, histology that are relevant for this.
So in terms of percentage, it all depends on what you call the denominator. 2% of what. So most of those studies were based on resection series. People have had a cancer cut out of their lung, and that's easy to stick in a library to go and look at later. And that tends to be biased by a particular histology called adenocarcinoma. So most of those numbers in terms of 3 to 5% are really talking about 3 to 5% of adenocarcinoma of the lung. Whereas there are other histologies, what the lung cancers look like down the microscope, squamous cancer, large cell cancer. And if you bring those in, that proportion would come down. So I think people went in assuming this was a number that was going to apply to all cancers, but it's really just focused down onto the adenocarcinoma. Although they do exist in these other histologies, but just at a much lower frequency.
And in terms of smoking status, it's certainly possible to see these in current or especially former smokers, but highest proportion is in the never smoking population.
And we saw that early on as we started
Right.
identifying patients, that it was very tightly linked to never or light smoking status. But as you said, a patient with a smoking history certainly can be at risk for a non-smoker's sort of lung cancer. So certainly that's why the guidelines are to screen everybody for this type of abnormality.
Yeah, and I'll say that I practice in North Carolina, where smoking is a little more prevalent perhaps than in Boston or Colorado. And I'll say probably about half of ALK that I've found have been in people with pretty real smoking history. And the point there is just that there's nothing about smoking that protects you against a non-smoking cancer. And so in practice, our standard of care is to test any non-squamous carcinoma, and that's probably one of the gaps between what we know is best practice and what's often happening in the real world, that probably there's not nearly enough testing going on, and then not nearly enough opportunity to exploit the advantages that we're all here talking about.
It's interesting because I have felt that if somebody has perhaps an EGFR mutation, if they are routinely getting an EGFR inhibitor as second or third line therapy, it's not as egregious a loss because you seem to benefit comparably whether you get it as your first or your second or even your third line therapy. But ALK is a different story. You only get your opportunity with it if you're tested for it. And so, if you're only looking in never smokers, you're not going to find it in smokers. And there have been, I think probably all of us have seen patients who you wouldn't guess based on their profile would have it, whether it's based on histology or smoking status. But you're only going to find if you're looking.
So you bring up a very interesting point. So the trouble is, not just with ALK, but with every molecular subtype that we find, the first series is published with a relatively small number of patients, and we say, they all have this histology or these particular characteristics. And there's a great tendency for that to then become fossilized into dogma, and people say, well, those are the only people you should test. And it's wrong, because if you stop looking after the first 20, you'll never find the exceptions.
Right.
Fortunately, the technology is now becoming more multiplex, so you just check one box for looking at a whole bunch of different markers, so it's going to be de facto testing everybody for everything fairly quickly.
And I think that will enrich our understanding quite a bit from the rather simplified, Asian never smokers have this or something.
Yeah.
So, and the differences between Asian and North American, largely Caucasian populations?
Yeah, we really haven't seen a difference. EGFR mutations are quite a bit more common in Asians. We've seen that. But for ALK, as well as ROS1 rearrangements across all the studies, it seems like there's almost no ethnic bias. So it's pretty similar, low frequency in Asians and non-Asians.
How about the issue we've talked about, you can be a smoker and have a never smoker lung cancer. I had alluded earlier to the responses that we get, not in everybody, but in a lot of patients with EGFR inhibitors or ALK or ROS with the right target for the right targeted, or the right targeted therapy for the right target, is fundamentally different from the kind of responses. So what is the concept of a driver mutation, and why do we expect and often see a totally different extent, depth, and duration of response than we do with standard chemo?
So cancers are often ugly-looking cells. They have lots of mutations and lots of chromosomal rearrangements. But some of these things that we've talked about, what we call oncogene-addicted cancers, are much more simple cancers. So we've shown that the ALK rearrangement must happen relatively early in the development of the cancer before most of that noise has actually occurred. And so they're actually, at a simplistic level, if you look at the normal ALK, so not the one that's gone bad, there are lower copies in an ALK rearranged cell than in a non-ALK rearranged cell, because that's just a normal cancer and they get multiple copies of all sorts of things going on. So it may be that these things just have predominantly one Achilles heel, and so you go in with one drug and you get this dramatic response because there's not all this other stuff driving the cell.
And the thought is that this driver is really signaling down these pathways down from this key protein. And by sort of overstimulating those pathways now, what they do, in fact, is confer dependency on those pathways. Those cancer cells rely on those pathways a lot. So now if you can just shut it off with crizotinib or one of these other ALK inhibitors, you shut down all the downstream signaling, and that leads to the death of the cancer cell.
Okay, great. So there's some cool animation for this one, and this is just a bit of an explanation of the concept of the rearrangement. I didn't do this, but and so a piece of the ALK gene is inverted and inserted back into the gene, and that's the so-called rearrangement that leads to the fusion protein of EML4 with ALK and a series of downstream effects. And there's lots of different variants of them, and that might be an explanation for why there's such variable outcomes. We don't see 100% response rates. We see 60 or so percent and another 25 or 30% who have minor responses or stable disease, but it's not 100%. So what about ROS1? What's the story, and why are we using an ALK inhibitor for ROS1?
Well, so ROS1 is another gene that's actually very similar to ALK, and when it gets rearranged, just like ALK, it can now be turned on. So now it's sort of turned on too much when it's normally not supposed to be on, and again, that's driving the growth of the cancer cell. And interestingly, ALK and ROS are very related proteins, and as it turns out, the main, what we call the active site of these proteins, where crizotinib binds, is almost identical. So ROS is actually just as good, if not better, of a target as ALK for crizotinib.
Okay, great. And do we have a sense yet of the duration or the proportion of responses with ROS? Because really what's been reported on is still not more than a dozen and a half or 18, 20 patients. And I don't think that the median duration of response had been reached.
Yeah, so I mean, so far, actually, it's a little over 50. We reached accrual, so it's about 51 patients, ROS patients enrolled, and the response rate is quite high. It hasn't yet been reported, but it's going to be over 60%.
Okay.
And as you said, the median, what we call progression-free survival, kind of roughly a surrogate of how long those responses are lasting, it hasn't even been reached yet. The patients have been doing very well.
That's impressive. Yeah.